Welcome back. We're going to spend some time now talking about some of the complications that can occur during labor and delivery. Previously, we talked about the normal things and how normal labor progresses and normal term labor. Now we're going to talk about some of the things that might go wrong that can alter the course of labor and delivery. Labor dystocia. That's a long, extracted labor. Things are not progressing like they were when we talked about them in the normal L&D. The 5 Ps can go wrong. We can have contractions that aren't strong enough. Those are called hypotonic contractions. The passageway can be too small. The pelvic bones are too small. Passengers too big. The position we talked about when that baby was occiput posterior, that can prolong labor and make it more painful. And then the psyche, when mom is fighting the contractions and not allowing the natural process to take place. Some of these might be associated with epidural, might be associated with multifetal pregnancy. Mom's just exhausted. She's been in this process for 24 hours or more. The pushing out of this baby isn't happening because mom's exhausted, because her contractions aren't strong enough, because that uterus is exhausted and it's not working at its optimum anymore. And then again, we know that if we have a bigger baby or an abnormal presentation, that can cause labor dystocia. We hear a lot about induction of labor and augmentation of labor. And these are on your prep sheet, but realize induction of labor is we start mom's labor. She's not contracting, so we do something to stimulate those contractions to get labor started. And that is not always for medical reasons. It is either a chemical way that we start it or a mechanical way. And we're going to talk about those in a few minutes. But 23% of the labors in 2011 were inductions. And that's more than doubled since 1990. And I would venture to say, although I cannot find statistics for 2017, 18, 19, I would venture to say this is even higher. And we do it because we've got a 4-day weekend coming up. We're doing it because, mom's tired of being pregnant. We're doing it because the doc's getting ready to go on vacation. And then augmentation of labor is the stimulation of contractions that mom is already having, but they may not be frequent enough or strong enough to be able to get the work done. So she's already contracting, but she's having dysfunctional labor, we call that. And so we give her medication to stimulate those contractions so they're stronger and closer together. When somebody isn't contracting on their own and we're trying to determine whether we should start their labor or not, we give them what we call a Bishop score. And we give them a score based on how dilated they are, how effaced, what that station is, what that cervix feels like. Is it firm or is it nice and soft? And then the cervical positioning. Sometimes those cervixes are so far, they're pointed so far posterior that it's almost impossible to even get to it during a vaginal exam. Or is it anterior, meaning is it lined up with the vaginal opening? And we know that if the first time mom has a Bishop score of 9 or higher, or if a multipara has a score of 5 or higher, then they are much more likely to be able to be induced with just medications like Pitocin. If they have a score of less than this, then we have to do things called cervical ripening before we can start our Pitocin, because we have to get that cervix ready to dilate. We can make mom have all these contractions, but if the cervix itself isn't ready, all those contractions are not going to be effective, or it's still going to take an extremely long time, leads to maternal and uterine exhaustion, and continues that dysfunctional pattern. So what do we do for cervical ripening? A couple meds that we use, those are on your prep sheets. I would encourage you to look at those. We use Cytotec, Cervidil, Prepidil. Those are prostaglandin medications. Some of them are gels, some of them are in a pill form, and we put them in the vagina right next to the cervix so that the cervix can start softening and get ready to be able to be induced. Some of the mechanical methods for cervical ripening: balloon catheters. It's like a Foley catheter. We put this in the cervix and we blow the balloon up, and it puts mechanical forces up against the cervix to cause it to start softening. And that can also, it kind of stimulates some of the prostaglandins mom already has and will help soften that cervix. Hydroscopic dilators such as laminaria or Lamisil. And what that is it's seaweed. It's like about half the size of a pencil in diameter. And we actually put that in mom's cervix. And because of all the moisture there, that expands, it puts pressure up against that cervix, causing it to ripen a little bit. We can do what's called an amniotomy. That's where we artificially rupture their membranes, AROM, artificial rupture membranes. And because of the vaginal exam, because maybe that can help get the baby's head down on the cervix a little bit better, it might help stimulate cervical ripening. And then we have this thing called membrane stripping, where we actually go in and we try to separate part of the membrane from the, like right where it's up against the cervix, so that again can stimulate cervical ripening. A note, there are going to be math questions on exam 2 about Pitocin. There's a document on Canvas for you called Pitocin Math. Please go in and review that so that you're able to do the Pitocin type questions. Oxytocin induction or augmentation. Our number one medication that we use for stimulating contractions to get labor started or to help stimulate them to get them more frequent or lasting longer or getting stronger is a medication called oxytocin or Pitocin. We're obviously not going to use it in the case where a vaginal delivery is inadvised, but it is our number one medication. Why would we stimulate labor if we're not planning on a vaginal delivery? The hazards that go along with using this medication is it can cause tachysystole. If y'all remember back to our fetal monitoring, that's when those contractions are way too close. And when they're way too close, our baby does not get well oxygenated, and our baby can start showing signs of distress. And what it actually is that the contractions are too close together. We can cause this tumultuous labor with tetanic contractions. Those contractions are lasting so long and they are so strong that we can actually cause the placental abruption that we talked about, or uterine rupture, can cause cervical lacerations, because this is such an intense, without allowing normal dilation. Those contractions are just so strong that uterus cannot take it. Because we've used so much Pitocin stimulating this labor, she's at risk for a postpartum hemorrhage. One, because that uterus is exhausted. It's been forced to contract more than it normally would have, and not under its own powers, that by the time mom delivers this kiddo, that uterus is exhausted, so it's more likely to relax, therefore causing postpartum hemorrhage. And then those consequent fetal effects because of these other things that we've caused because we've used our medication to stimulate this labor. How do we do this and do it safely? Well, we administer it under an IV drip that is always, always, always on a pump. We piggyback it into the main line, so we want this at the most proximal port. We start at 1 to 2 milliunits a minute, and that's like just a drop, because we want to mimic normal labor. We want to just start very slowly, see how much it takes to get her started. And so we start at 1 to 2 milliunits a minute. We're going to increase by 1 to 2 milliunits a minute every 30 to 40 minutes. Now, every hospital has a very specific protocol. I have seen protocols where we start at 1 to 2 milliunits a minute, and we double that every 20 to 30 minutes. This now puts this pregnancy, this labor and delivery, in an at-risk category. So we have to monitor for contractions the duration, the frequency, the intensity. Remember, anytime you talk about contractions, you're always going to talk about frequency, duration, and intensity. What that resting tone is in between contractions, what the fetal heart rate is, maternal vital signs. All that's being done every 15 minutes now that she's in this higher risk category. And we're going to monitor for labor progress. And again, that does not mean that we're doing a vaginal exam every time we're doing this. We are always going to discontinue our Pitocin if there are signs of fetal distress. If you will remember that our actions for anything showing fetal distress, whether that's decreased variability, late decelerations, prolonged variable decels, we're going to turn IV O2. We're always going to turn off the Pitocin. That is always going to be one of our actions if we have a baby that's in distress. Uterine tachysystole, we talked about this during fetal monitoring, but as a reminder, those are those contractions that are more frequent than every 2 minutes, lasting longer than 90 seconds. And it also means if we have a resting tone greater than 20 millimeters of mercury. The only way we're going to know if we have a resting tone greater than 20 millimeters of mercury is with an internal monitor, intrauterine pressure catheter. However, we can palpate her uterus in between contractions to determine if that feels like it is soft. If it is, we don't need an internal monitor. If we're questioning whether that uterus is soft in between contractions, then that might be an indication to get our intrauterine pressure catheter. If we end up with uterine tachysystole or this non-reassuring fetal heart rate, we're going to turn that infusion off and do the things that we talked about before. Mom on her side, O2, IV bolus, contact our primary care provider. We might need to give a medication called terbutaline, which is going to help stop those contractions. And then we're going to document the response, mom's response, and always the fetal response to all these actions. Another complication we might have is called shoulder dystocia. And that's where this baby's head comes out and then they retract back because those fetal shoulders don't turn and do the usual cardinal movements that we talked about. It's kind of where that anterior shoulder, that upper shoulder, gets stuck under the symphysis pubis. Risk factors for this is that we have an increased size of our fetus, maternal obesity, excessive weight gain during this pregnancy, contracted pelvic outlet, or a protracted labor. That's that prolonged labor. And again, that might be because that uterus is exhausted, not contracting optimally, so it doesn't cause those usual cardinal movements. Some of the complications, trauma to mom's pelvis or trauma to our fetus. Our babies can have fractured clavicles. They can have a brachial plexus palsy where the nerve in their arm actually gets damaged. That could be temporary or that could be permanent. Because of this, these babies can be asphyxiated and they can die. How do we recognize this? Delay in the delivery of the shoulders following delivery of the fetal head. And it's what we call a turtle sign. And so their head comes out and delivers. And remember, if they're occiput anterior, which is the direction we want them in, then their head comes out and their chin lifts. And then almost immediately their body rotates and rotates like a corkscrew and rapidly delivers. Well, if this kiddo's head comes out and they deliver their chin and then their chin is kind of tucked back down, and imagine their nose going back down on mom's perineum, that baby does not rotate and does not do that kind of explosive delivery after that head's delivered. And I put this picture here because I want you to think of that turtle sign. The head recoils back up against the perineum. Head is out and then it comes back down. Spontaneous restitution that we talked about in our cardinal movements does not occur. Failure of delivery of the shoulders does not occur. So baby's head comes out, now you see me, now you don't. It doesn't ever retract all the way back in like in this picture, but that's as close of a picture as I could get for you. How do we prevent this? Aware of the risk factors. Does this mom represent any of these risk factors? Prompt recognition as soon as this retraction of the fetal head occurs. And then let's get this kiddo delivered. We want to avoid excessive traction, downward traction on the fetal head, trying to get that anterior shoulder under that pelvic bone, because we can cause some neck trauma in our kiddos. A shoulder dystocia is defined as the impaction of the anterior shoulder against mom's pubic bone after delivery of the head. How do we help fix this? One of the first things we're going to do after we recognize this is what we call McRoberts maneuver. That's where mom pulls her legs up as far as she can get them, and we help her get them up as far as we can get them, and we get her knees out as far as we can get her knees out. And what that does, it actually opens the diameter of the pelvic bones so that baby can fit underneath there. While we're doing this, if that doesn't immediately fix this, we're going to do suprapubic pressure. That means somebody's probably on a chair, on a step stool beside the bed. They're putting their hand right here above this symphysis pubis and pushing with a downward motion. And what that does is it helps kind of collapse the fetal shoulders so that hopefully we can get that shoulder underneath that pubic bone. We do McRoberts maneuver, legs up and out, and then suprapubic pressure to get those shoulders underneath this pelvic bone right here. This is the fundus up here. We are never going to do fundal pressure. Never do fundal pressure. We're pushing right here, thinking that we're going to push this baby down. What we're actually going to do is maybe cause an abruption or a uterine rupture. So we are not doing fundal pressure. Sometimes a very generous episiotomy, and again, I've said this before, I think, anticipate resuscitative support of the baby. We should anticipate every baby's going to need resuscitation, therefore we should always have our equipment ready. Just like every day when you go to work, you should anticipate there may be a code. That's why you check your crash carts every day. If these don't work, we're going to get her in her hands and knees position, because what that can do is cause that baby to drop. It can help open that pelvis a little bit so that baby might be able to deliver. The McRoberts, suprapubic pressure, our episiotomy, hands and knees, and if those don't work, then we're going to go to a cesarean delivery. We have 7 minutes from the sign of the turtle to deliver. Most of the time, our McRoberts maneuver and suprapubic pressure are going to be effective. When that doesn't help and we can get her on her hands and knees and we get them delivered, we can usually get them delivered within that 7 minutes, and we've saved a cesarean delivery. And what you have to remember is not every hospital is set up like the hospitals here in the Metroplex where you're doing your clinicals. Some of our rural facilities, we call the OB doc in. He's not in-house 24/7, so we call him in for this delivery. We have this happen. We have to call anesthesia in. Anesthesia's not in-house 24/7 in all of our hospitals either, nor is the OR team. And so most of the time, especially in some of our rural facilities, McRoberts and that hands and knees, we've got them out, that baby out before we can get OR there and ready. Another complication is an umbilical cord prolapse. That's when part of the cord delivers in front of the baby. It can be you lift up the sheets and there you see the cord. It can be that when you do an exam, because you have this huge variable that does not go away, then you do an exam and you feel the cord in the vagina, or you do a vaginal exam and you sweep around, feeling around that baby's head, and you feel that cord right up against the baby's head at the cervix. What are some of the risk factors for that? Anything that prevents engagement of that fetal head down in the pelvis, when that baby remains at a high station, -2, -3, and she's ruptured, that cord can come down in front of that fetal head before delivery. An amniotomy, that's where we artificially rupture mom's membrane, should be delayed until that fetal head is engaged on the cervix. Here's a picture of a breech baby, but this cord, here's the cervix, here's the cord down in the vagina. Here's a vertex baby, but here's the cord down in front of baby's head. And the problem with that is this gets entrapped in between the uterine wall, the vaginal wall, and the baby's head. And so when you see this, it's a cord, so you're going to see big variables on the fetal monitor strip. Again, cord down in the vagina. This is a cord that is actually outside, so we're seeing this externally. And so again, probably big variables, because here's the cord coming back right up through here. If mom has a contraction and this baby's head gets pushed up against here, this is going to get compressed, so you're going to see a variable. What do we do about this? We do a vaginal exam where we go in and lift the presenting part, the head or the butt, lift that up off the cord, and then that person is staying there in that position until we get this mom in the OR and get this baby out, because we cannot allow no blood flow through this cord. Causes fetal asphyxia and can lead to fetal death. What are our signs and symptoms? That we actually see that cord, or we can palpate it on a vaginal exam, or we see our fetal distress on our monitor tracing. Knee chest or Trendelenburg. This knee chest, she's on her knees, but now instead of being up on her hands, she's actually got her chest down on the bed. And what that does is allows gravity to cause that baby to shift back toward mom's head a little bit to maybe take some of this pressure off that cord. We're going to lift the presenting part off of that cord, and then this is a stat C-section. There is no waiting on this one. Now, if that means we're at that rural facility where we have to wait for the OR team to get there and anesthesia, it might mean that nurse is sitting there holding that presenting part off that baby for 10, 20, 30 minutes until we can get her to the OR. So this is that knee chest and allows gravity to let this baby come back down and take pressure off that cord. Unfortunately, we have uterine rupture. We talked about this a little bit when we were talking about our high-risk conditions in pregnancy. Remember, this is a tearing or an opening of the uterus. It's usually from a scar from a previous surgery, and the risk factor is a previous surgery, obviously. Those tumultuous labors that we talked about, really intense, strong contractions. Multiparity combined with Pitocin administration. Obstructed labor, meaning that we're trying to put this kid through a pelvic structure, the bony structure of the pelvis, that is too small to accommodate this fetus. Excessive fundal pressure that we talked about, use of forceps for delivery, violent pushing, and that, again, we can resolve by, if you'll remember from our normal labor discussions, that means that open glottis pushing that's mom directed. This can come from a shoulder dystocia, and we said trauma when we talked about it earlier. Complications, pain, hemorrhage, DIC and death in our moms, and hemorrhage and death in our fetuses. Signs and symptoms, that abdominal pain, which again we may not realize because of mom's epidural, so we have to be watching. Failure to progress. Palpable fetal parts when we do Leopold's maneuver. Instead of being able to feel here's the bumpy side and here's the smooth side, this is where we can actually identify knees and shoulders because it's so close to the surface and because that baby's no longer in the uterus. Signs of fetal distress. All of a sudden, we have a loss of uterine tone. If that uterus is ruptured, it can no longer contract. How do we deal with this? An emergency C-section, fluid and blood replacement, and then resuscitation for our babies. Anaphylactoid syndrome of pregnancy used to be called an amniotic fluid embolism. That's where part of the amniotic fluid that contains that vernix, it might contain some of the lanugo, it can contain meconium, which is the baby's first bowel movement, that somehow there's a break where the uterus is attached with the placenta, there's an opening there, and part of the amniotic fluid gets introduced into mom's bloodstream. It occurs in 1 out of every 15,000 to 20,000 pregnancies. The reason we talk about it is because it can be catastrophic when this happens. What are the risk factors? Multiparity, we have an abruption, short tumultuous, those very, very powerful contractions, or oxytocin augmentation or induction, where we have caused this tumultuous labor, macrosomia, in the case of IUFD, intrauterine fetal demise, and in our operative births. It acts like it is an embolism, but instead of a blood clot, it's an embolism that has amniotic fluid and maybe some other particles. Travels through mom's bloodstream and acts like an embolism. They have acute respiratory distress, cyanosis, cardiovascular collapse, profound shock, and this is intense and rapid. When we've talked about hypovolemic shock in our earlier lectures, we talked about how well mom can compensate. This is a cardiovascular collapse, so this is cardiovascular shock. It is extremely profound and quick. Leads to coma, DIC, and can lead to death of our moms. Mortality is 86%. Signs and symptoms, that acute respiratory distress, cyanosis, cardiovascular decompensation, and then bleeding. What do we do about it? Because it tends to be respiratory, that's the signs and symptoms. We're going to get our oxygen, ventilator support, blood gases, blood replacement products, heparin, invasive hemodynamic monitoring, CPR, and if this has happened prior to the delivery, it's going to be an immediate stat C-section. All right, now it's time for a break. Take a brain break and then come back and let's finish our high-risk labor and delivery complications.